So welcome to today's webinar resident series, Introduction to Implant Dentistry. Part 1, Implant Biology, Patient Selection and Indications, Treatment Planning and Implant Placement. It is being presented by Jean Peterson, MS, CDT of Sterngold. And with that, it is now my pleasure to introduce Adam Dreyfus, Director of University, Government, and Institutions. Take it away, Adam.
Oh, good morning, and thank you so much, Jessica, for the warm welcome, and thank you to our participants for showing up. I do want to, first and foremost, say thank you. We know at NDX you have lots of choices, you have lots of partners, and we do thank you for your continued partnership, and we look forward to supporting you today, tomorrow, and for the future, as I always say. Today's presentation is very exciting. And I will join you at the end of the presentation, but I know that you all have a lot of things to get to. So without further ado, I'd like to turn it over to our esteemed speaker this morning, Jean Peterson from Sterngold. Jean, please take it away.
Thank you, Adam. Good to be with you this morning. And everybody stay warm. I know you guys, if you're not in the Northeast, you probably don't know what we're talking about, but it can be vicious, which I think today is going to be an interesting day on a lot of fronts. So, we're actually located in Boston, and we're supposed to be getting a foot of snow today. So it's an interesting day, but it's winter time, and we love it. We love the snow, and we love just patience. So let's just move on. I hope you're in a good place right now to sit back and talk about implants. Just to give you a little bit of a background, my name is Jean Peterson. I'm the Director of Technical Development and Learning at Sterngold, and it's been my pleasure to work with NDX, Adam, Jessica, in the whole realm of university education. They provide a great service for you all, and we're pleased and we're honored to be able to participate in this as providing some content that can help you in your education journey. I'm a big advocate of this type of education because at the various levels of where you want to be in your careers at this point is very different depending on where you go to school. And I think you all learn a little bit about a lot. And I think if you can learn a little bit more about certain things, you can feel more comfortable. So especially in your residencies. So that's why you're in residencies, to get a little more of that education and to drill things into you better. And it's an exciting time right now because there's so much to learn. There's so much to learn after school. That's out there. And today we're going to give you a little bit of an introduction to of implants, of implant dentistry, and given that understanding that many of you have experience in this already, and some of you don't. So this is an introductory lecture, and it's really made to create questions and further desire to learn about these subjects, and really give you more of a platform to grow. So if there are questions you have, let me know. If you want to dig deeper, you can ask questions in the chat box. But we're just going to take an initial view or an initial approach of implant dentistry, and we're gonna talk about what we can do. At Sterngold, we do manufacture implants. That's what we do. And we do conventional implants, we do small diameter implants, and we do guided surgery. We're involved with all aspects of implant dentistry, all the way up to the hybrids. So it's an exciting time in dentistry right now because even though implants have been around for a long time, there's still a lot of I guess the greatest thing about implants is to become they've become such commonplace, and it's really a go-to treatment now, where before 20 years ago it wasn't. So let's go ahead and get started because we do have we're a little cut short this morning, but we'll get in as much as we can. So the first slide here, we're just going to talk about what is a dental implant. When a tooth goes south, I mean, the whole idea of dentistry is we want to try to preserve everything we can about the tooth, from when you first get into somebody's mouth to correct a decay. We want to prevent more things happening because we know that the cascade of events begins when that tooth goes bad, and you start with a crown, you start with an endo, and then once endo happens, it's usually the beginning of the end. You want to make sure that you don't lose the tooth, okay? But it's probably going to happen at some point in time, and the best way to replace that tooth in many cases can be an implant. Now we're going to talk today about patient selection and thinking that, you know, a lot of times folks get out and they think, well, geez, I can put an implant in every patient. Well, we really can't, and that's part of the failure of the numbers, the stats that are out there right now in implant dentistry, because it's actually, you're going to be quite shocked about how many implants really do fail. We see them on a daily basis in the literature. In my position at Sterngold, you know, we have implant failures. Everybody has implant failures, and we have to investigate why they fail, and we want to understand why they do, because there's many different reasons why they fail, and we're going to talk about that. But really what we're trying to do is replace that tooth root, okay, with the best possible prosthetic and, you know, alternative to put a prosthetic on, and that would be an implant, because really an implant is a root replacement. It's a root form fixture that goes into the bone and it integrates and it becomes a sturdy platform for restoration. It's usually made of titanium. There's a lot of work being done right now with zirconia implants, big in Europe. I'm not going to talk much about those today. They've got their pros and they've got their cons. But titanium is really the material of choice, because it is so biocompatible. And at the end of the day, we want to make sure that that implant integrates in the best way possible. Dr. Brandemark decided that was, and it's been proven time and time again that titanium is the best material, at least today, for that, with notwithstanding the arguments towards zirconia implants. And that implant is going to be attached to an abutment, and it's going to be affixed to a crown or a bridge or an overdenture. And that's a whole nother thing that we can talk about, is overdentures, because really I take this lecture and we start with overdentures. In implant dentistry, other than single tooth implant dentistry, you really need to understand dentures to be able to learn to plan your cases, which is another lecture that we can have at another time, because it's very fascinating to see how your denture principles apply to, and necessary, how they apply to implant dentistry, both for occlusal forces, distribution of all the loads. It's very important. It's very similar in concept. And it very much is. The implants are state of the art. They're state of the art tooth replacement. Everybody seems like everybody's placing them. Because why? Because it does mimic the natural tooth, and it is standard of care. So what are the parts we're talking about? You know, generally speaking, we've got the root form, which is the titanium screw. They are generally not coated with anything anymore. They're treated, which we'll talk about, which enable the integration a little bit better. There's an abutment which actually screws into the implant, and there's a prosthetic. There's a crown. Or in the case of overdentures, there's an attachment which snaps onto a denture, and that can be done in a couple of different ways. That could be done through a straight abutment or an angled abutment that is prefabricated, or it can be associated with a tie base. And tie bases are really popular now because they're so versatile, especially in the digital world. Because the tie bases are in the software, and in your 3Shapes and your exocads, etc. You throw in the parts, and you can literally, in 3Shape, you can make a one-click crown now. So it's very convenient, very good way to go. So, and I think that you also have the custom abutments, which would fall under the situation on the right. So either way, there's an abutment. There's something that's attaching to the fixture that is the interface between the crown and the implant. What are the major concerns with implants from the patient's point of view. Is it fear? Is it the time required? Is it the cost? I would say personally, from experience, that none of these things really apply anymore. I know that's easy to say from a patient who has these fears, but the relative cost is down. The overall experience is good. I mean, it's not. I mean, implant surgery is not uh, very traumatic anymore. I mean, it's not. I mean, you get the patient anesthetized and the implant goes right in. And at time, if it doesn't take much time to do an implant, we're talking single crowns. There are single implants now. Um, so it can be a very efficient treatment plan for your patient if all the stars line up and you can actually do an immediate load on that crown. Most of the time we're going to let the implant heal, which is a good which is good advice, but it it's generally these three factors, which were problems in the past, aren't that big of a deal anymore. Okay, so advantages of implants, they function like teeth in the best way possible. They do replace that natural tooth. The biggest thing is, as we talked about, we know you as clinicians, you want to preserve bone. We don't want to lose the bone, because that at the end of the cascade, that's what happens. So we want to do everything we can up the cascade to prevent that, from brushing your teeth, from the very simplest step. Don't cause that tooth to be restored, because once it goes to endo, there's a very high likelihood that over some amount of time that tooth is going to fail and it's going to come out, and then what happens? You lose your bone, and that's what we don't want, because that's there's great bone regeneration procedures now. But at the end of the day, we're trying to prevent the bone. And how do we do that? Keep the bone stimulated, and that's keeping something there to preserve it. So an implant can do that. We just the same as a natural tooth does. So we want to, or we can actually prevent and preserve bone, or prevent bone loss and preserve bone. They can be highly aesthetic. I mean, nowadays with all the advances and excellent technicians that can design the properly emerging prosthetics with their clinicians. I mean, you can't even tell in the anterior now, if there is an implant. So they can be very natural looking, and they're a great option there. They can last a lifetime. They can last if they're taken care of. Now there is a little bit of a paradox there, because why do they have an implant to begin with? Well, they didn't take care of the teeth. Well, now they really do, because they still have to maintain that implant site, and you got to make sure that it's clean, because if you don't, what's the alternative? You still can lose the implant. It can fail. It preserves adjacent teeth. You don't have to prepare for bridges, so you're preserving. Again, we're preserving tooth structure. I mean, when I first got into this business 29, 30 years ago, the option of doing bridge, everybody did a 3-unit bridge. That's before implants were popular. And what are you doing with the bridge? You're sacrificing 2 adjacent teeth, and if we don't have to do that, we don't have to do that. Most important, we're restoring quality of life, and that's what you're in the business for. Is really you're helping people get back to the point where where they want to be. And it's a psychological thing. It's both functionally and psychologically beneficial to the patient. By doing that, you're also going to restore natural food to their diet. Regular natural biting forces. They can eat what they couldn't eat before. In the conversation of overdentures, denture stabilization is very important. You can. I really enjoy giving the talking to clinicians, especially young clinicians, about the importance of overdentures, because this is a real simple, easy way to help patients out and restore that quality of life in a most probably uninvasive and economic fashion, rather than doing it all on floor, for example. Denture stabilization is a really great way to go because most dentures don't fit very well. And the ability to secure those in the mouth with a simple implant or a couple of implants is a huge advantage to that patient and their improvement in quality of life functions. Improve their speech. You can add, to those. You can link future restorations, and it's retrievable. It's a big deal to be able to change out the prosthetic if need be, because with implants and abutments, the ability to retrieve that implant or that prosthetic and the abutment is very important, because you don't want to be committed. Now, there are certain situations where you need to be committed and you can choose to be committed, but we'll talk about that at another time. But in today's discussion, the ability to have retrievability is very, very important. And most important, you want to be able to provide a complete treatment plan for your patients. Surely you don't want to pass somebody down the street, or you don't want to push them down the street to the next guy or the next girl, and you want to provide them the work. You want the work. You want the production. So being able to offer implants as a GP, as a specialist, I'm not sure what residencies you're all involved in, but if these are GPRs, implants are all over the general practice world right now, and they're very, very good and highly qualified and trained clinicians in the general practice world placing implants, and you can get some really good education from them, and you probably know people that are very successful doing them. It's a great way to go because they have a complete offering. They want to do that, and or you can go down the road to the periodontist, the oral surgeon, the prosthodontist. But that's, specifically that's what they're trained for in school. So, but really you're providing a complete treatment option for your patients. Okay, patient selection. So this is in my work at Sterngold. One of the things that I have to do is I have to report. So this might be some good information for you. If you have an implant fail and you report it back to the manufacturer, they're by law obligated to report that to their regulatory body, okay, the FDA, because we have to make sure that there's no adverse event associated with that implant. Imagine if XYZ implant company created an implant and all of a sudden they started fracturing and pieces started going, breaking off and it being aspirated, and people suffering, catastrophic consequences. What we have to do is we have to report that, and we have to make sure that did not happen, make sure there was no adverse effect. Now, hardly any implant failure that, in my experience, has resulted in a catastrophic event, but they do. And what happens then? Well, you gotta do recalls, those bad R words for manufacturers, and you got to take necessary steps to prevent that from happening again. And so, as a manufacturer, it's our obligation to make sure that implant when an implant's returned, whether it's been dropped on the ground, whether it's failed, whether it's it's failed after 3 months, after 2 months, after 1 year, 2 weeks, whatever, we have to do that investigation, and that's not a bad thing. That's just necessary. That's due diligence to the industry. Really, it is, because we want to make sure that we're providing the public, products that are healthy and safe and not going to cause any more harm if there were a problem. So, with that said, most of the implants that are returned, nearly all of them don't have any adverse effects associated with their failure. What that does is we look at 3 different things. We look at manufacturing problems, or anything that have to do with previous lots or batches within that implant line or that failed. The other 2 things are patient selection and operator error. Okay, so you pretty much have to once you rule out any manufacturing defects, because it's not the manufacturer's fault if the implant's dropped in the ground. And you should know that if you contaminate the implant, don't use it. Implants shouldn't be re-sterilized. They shouldn't be cleaned off. There are a lot of ways to contaminate that implant that can cause failure as far as its ability to integrate. And that needs to be a very clear point that's understood. So it's not bad to return these. It's just because most implant companies will return your implants if something like that happens without any questions. They're glad to do it. I mean, at Sterngold, we don't ask questions about it. We just say, hey, absolutely, let's get that good implant. We'll replace it for you for free, and we'll worry about everything else at the end. But the other reasons, the patient selection and the operator error, that's what we're going to talk about today. So what we want to talk about is first, we're going to talk about patient selection and the importance of, can we put an implant in every patient? And really, the question is no, probably shouldn't. We should probably consider whether or not every patient is a good candidate, because we'd love to use that as a treatment plan. But as you know, as clinicians, not every treatment plan is the best for every patient. So we have to understand that where we're placing the implant is and who is the appropriate choice. So we got to talk about bone quality. So we want to make sure that the bone quality is a sufficient quality and quantity that is required for that implant to stay in place. Because the last thing you want to do is place an implant, spend all that time creating your osteotomy, and the implant spends on you. If there's not adequate bone, then we need to do something different. We need to augment that. We need to change it. We need to do some guided bone regeneration. We need to create a situation where we have quality bone to place the implant. Because if you don't, even if you let the patient heal, the implant may never integrate sufficiently to have primary stability to place the restoration. And what happens after that is, if it continues to be restored, then it'll fail. It'll fail, and so that's on you now as a clinician to bring the patient back in and explain to them why their implant failed, because they don't know. They just want to have a tooth, but there are many reasons why the bone is the way it is, or their comorbid situation, their health history is such that they shouldn't have one. You want to make sure that the patient is in generally good, supporting tissue-wise, in good health. You want to make sure that they are in a situation where it's going to allow for healing. You don't want a lot of inflammation that's going to cause any problems with the bone healing, because that's what we're talking about now. Is we're talking about integration of that bone to the implant. Overall patient's health history is really important. And this is something that we look at carefully when we do a return. We send a questionnaire out to the clinician, and we ask about the patient's history. So, if you place an implant, you have a failure, and your implant company sends you this questionnaire, don't look at this as something, well, I don't want to get in trouble for something, but look at this as something where you're providing information that is going to be very beneficial to trying to, help you determine what caused that implant failure, because there are questions on there about the patient's health history, about current conditions, about medications that would help the clinician understand what possibly may have caused that implant failure. Because there are many combinations of situations where that implant may be doomed from the very beginning, from when it was taken out of the package. The restorative, I mentioned earlier about denture knowledge and about occlusion understanding. That is very important, because if you prosthetically, every implant should be prosthetically designed and placed, okay? Because the occlusal forces associated with an implant are very, very critical, because you could design an implant or placement where the prosthetic could totally contradict the position of that implant, okay, and cause it to fail due to the forces, because it's going to move and it's going to fail. So that's very important. So you need to work very carefully in your pre-treatment planning with your pre-treatment model study models and your technician, and design a case that you know is going to function correctly and not cause undue stress on the implant due to its design. And I can't really emphasize that enough. That's very, very important. And it really comes into a lot into the conversation when we talk about full mouth rehab, hybrid, all on fours. That's very critical. And that really does start with, a full denture type design where you get the patient stabilized in their occlusion, and then you design the implant placement beneath it. So let's dig into this just a little bit here. So bone quality. It's important to understand through you can bone sound. I don't think they probably don't even teach that anymore, the old way of doing it because of the CBCT technology right now. But really, in the I say the old days, I'm not that old, but I mean in the old days before CBCT, the clinician had to literally probe the bone and estimate what the bone quality was based on feel, okay, and to a certain extent the quality of the radiographs. But it's important to understand what the quality of the bone is. Now with CBCT, it gives averages and it tells you exactly what bone quality is in every position of the bone, and you need to understand that. In making this, in its most simplest terms, and if you were to think of bone in terms of, types of wood, the very hardest bone is what, D1 type bone. This is very, very dense cortical bone. It's, you compare that to maple. It's something that's really hard to drill into. When we place mini implants in the anterior, in the mandible, that's very avascular, very dense bone. And so these implants are designed different to go through that hard bone. There's in surgical kits, which we'll talk about. There are different types of drills for cortical bone, for dense bone, that cut more efficiently in that type of bone. It'll depend on your drill speeds and the types of drills you use. So because you can burn up drills real quick and create more problems for yourself if you don't consider that. But most of the time, that dense type bone is going to be in your anterior mandible, and as it moves posterior, you're going to start getting a little more softer into type 2 bone, which would be more like your pine wood, a little less dense, and you're starting to get a little more vasculature, which is going to be most of your mandible, your anterior maxilla, and then as you move posterior, the bone generally gets softer, especially in the maxilla. You get type 3 bone and you have type 4 bone, which probably you should avoid. If you know you have type 4 bone, which is very, very fine trabecular bone, you probably ought to avoid that. I mean, even though implant companies take a lot of time and effort to design their thread patterns to be more aggressive for type 3 bone, type 4 bone is very, very difficult to place implants in. And what you're looking for is primary stability, and you're looking for a certain amount of tightness that's measured in Newton centimeters. That is considered in the industry, quote unquote, primary stability. That means, is it tight enough? Is it going to be in the mouth tight enough to place a restoration on it? Because there is a point where that implant's going to be as tight as it's going to be based on the time. Well, based on the time that you place it, you're going to know, because you're going to place the implant, you're going to test the torque. And if it's at a certain number, you're gonna know, okay, it's there, and you could very well restore it at the time of insertion based on that tightness. And you can, in the many clinicians, many experts feel that no matter what the situation is, you should allow that implant to heal. You should allow it, no matter what the primary stability. You should allow it time to stabilize, to integrate, because that healing period is going to, it's going to vary from 4 to 6 months depending on the patient's health. but that allows the patient that bone to integrate better, and it gives you a better platform to restore on. With the different types of bone, it's going to affect how fast what your speed is. Generally, the more dense the bone, the higher the drill speed is going to be. Because there's two types of damage you can do to the bone. You can do it either by heat necrosis or pressure necrosis. So you could, if you don't drill fast enough, what you're going to do is you're going to damage the bone and not allow it to heat, not allow it to integrate. It's the osteogenesis part of the process is not going to occur because of damaged bone. And that can also happen because of too much heat. So if you're too slow or you don't have enough cold sterile irrigation in your osteotomy preparation, you could damage the bone that way as well. And then that'll be your beginning of the end, because once you damage that bone, either by heat or pressure, you're not going to be able to achieve any type of integration, generally speaking. What you'd have to do is, if you realize that you drilled too slow or you heated it up too much, you're going to have to refine that osteotomy. You're going to have to refine it, choose another site. You're going to have to place a larger implant. I was in an office a couple of months ago where the doctor felt that he had done something like that, and so what he did is he backed the implant out. He regenerated the surface via curettage, inside the osteotomy, and placed a larger implant. He basically brought virgin bone to this to play inside the osteotomy that would allow for osteogenesis and integration. So there is that concern, but generally speaking, we're going to talk more about drill speeds, but generally speaking, you're talking, in the neighborhood of 12 to 15, something even like 1800 RPMs, and it depends on your drills, because the drills can get dull. They're not they don't live forever. But that's up to the clinician. There's a definite feel for the way that that your drills are drilling efficiently, and you need to be able to decide, this has been done properly or not, based on your experience there. So understanding the bone quality is very very important, because you definitely don't want to place this implant into an area, and especially load it when you're not going to be able to achieve that primary stability. This image here, I was just telling you about how convenient it is now with CBCT technology, that it can tell you exactly what your bone values are, what your bone density values are, and in Hounsfield units, T values. There are different ways to measure that, but you want to make sure that you're in the vicinity where you need to be. Okay, indications. In most situations, implants are a good option. Okay, I'm talking about now when we're talking about treatment planning. Can it be used here and not there? In most edentulous areas, notwithstanding everything we've talked about as far as bone quality and patient health, an implant can be indicated. Sometimes patients can't tolerate, complete dentures at all. They can't have it, and so it'd be warranted to place an implant over a denture. Single tooth loss to avoid involving neighboring teeth. We talked about that. Unfavorable number or location of potential abutments. You don't want to have it too busy. We can go too far, and put too many implants in. Poor oral muscular coordination. That would have to do with, other alternatives, that would, like, placing a denture. Low tolerance to mucosal tissue or periodontal disease. That's, make sure that, if you want your patients to be healthy, and their parafunctional habits need to be at a minimum too. So you need to evaluate what potentially is going to happen after. you place the implant. If if they have a hyperactive gag reflex and can't tolerate dentures, again, something that sometime to continue or to consider implants. Some people just don't want to wear a denture or a removable prosthetic. The psychology behind losing teeth, whether it's one or all, is huge. If you've ever been in an immediate appointment where somebody walks in the office with even one tooth left, and they walk out with nothing, it's a big experience for them because it's traumatic. Because all of a sudden they're left to go home with basically and essentially a gum cover, a denture, and they're told to eat and survive. That's very psychologically. It very much psychologically affects the patient. I've seen it so many times, and so the ability to assuage that with some implant placement is a good indicator. Obviously for trauma, they're good. It's good indications there for repair and congenital problems. Disadvantage, yeah, it can be expensive. Implants, even though I saw a billboard yesterday on the road that said implant and crown $1,000. Well, I don't know. That's getting close to over the border dentistry, travel dentistry prices. So you got to be careful there. But yeah, generally speaking, to a good clinician, implants aren't the cheapest option. Sometimes patients don't like surgery. They do have an aversion to the thought of, that we're going to have, they don't want to be operated on, quote unquote. I was in Green Bay, Wisconsin over the weekend. Last weekend, we had 3 patients lined up with a prosthodontist, and this lady she needed implants. She wanted implants, but she just could not handle the idea that it was surgical. I mean, she walked into the operatory and it was set up very sterile, and it was, she thought she was going to be undergoing surgery, and she started, complaining the second they gave her the anesthetic, and she complained all the way through it. And I've had implants placed, and you placed implants maybe, and it's not that big a deal. But that you can't overlook the patient's perspective on things because they just don't want to do that. So that's your decision. There is a learning curve. Sure, can you go to an implant course over the weekend and learn how to place implants? Yeah, maybe. What are the alternatives? Well, you really want to be trained as best you can. There are implant residencies, there are many implant residencies. There's really good training out there. I would recommend you get the best training that you can in implants. You'd probably agree with your colleagues that it's probably not the most difficult procedures to do, as long as you plan correctly and you do your due diligence. But there is a learning curve, but it can be learned. In the world of GPs, it's a great way to expand your offering, because something that's relatively I don't like to use the word easy. It's not easy because but it's another procedure that you have to learn. Okay. I'm just going to leave it at that. The fact that there are, prudently speaking, there may not be immediate results. Patient may not want to wait 6 months for healing. There are, for the multiple appointments, because sometimes implant visits can become burdensome as far as the frequency of the appointments. The complications that can arise. I mean, because we've talked about some of the complications that could cause potential failure, and that is something that can be a problem, and we're going to talk about that next. But generally speaking, I would say that implants can be a good option, but there are some disadvantages that you always have to consider. And once you have that implant patient, as with most treatment plans, you own that patient. You're accepting all the previous problems they had, and you're going to have to deal with it. So you have to carefully consider, as much as you'd want to put implant in that place, in that patient, should I? Okay. And I think you'll learn that over time. that as you understand patients better and understand what can happen on the back end, that you'll probably learn how to make that decision more easily. All right, so contraindications. This is a big deal. So that patient selection is probably one of my biggest um, um, desires for a clinician to understand, because this is what I see. This is what I see in the real world on implant failure and returns. Most of the time, I'm just going to say, I'm not going to put a number on that, but a majority of the time, it comes down to patient selection. And again, we want to help these patients. We want to put the implants in, but should we? If these patients are having any type of acute illnesses where their immune system is lowered, don't do it. Okay. If they've got insufficient bone that's gonna cause any type of intervention with the nerve, don't do that, obviously, because you can get yourself into trouble really, really quickly there. Any medically compromised patient, if I've got diabetes, if they've got heart disease, high blood pressure, high cholesterol, those can be controlled. The fact that they have those situations are not bad, but the problem is if they're not controlled, it can be bad because the medications that are involved are contraindicative to the healing process. And that's what we're going to talk a little bit more about that as we go down this list. But consider that and ask them to, make sure that when you do your pre-treatment investigations, that that they try to be as, forthright as they can with, because you don't know the patient. They usually know. You can usually tell if a patient really knows about their diabetes if they can give you specifics about it because they know about it. Or they can tell you their medications for their heart problems, their cholesterol, or their blood pressure. Those are things you need to consider. Bisphosphonate therapy. That's a big downer on blood coagulation. Obviously the anticoagulants are bad. Anything that interferes with the healing process is going to be something that you want to avoid. Tobacco tremendously inhibits the healing process. Any types of terminal illness that may be obviously influencing their immune system or causing them to take medications or radiation. I actually mentioned that, I think, here. Pregnancy, consider that one. That one because you don't want to cause any infections that could hinder in both pregnancy process or the healing process of the implant. Any type of chemotherapy, radiation treatment is not a good time to place an implant. If there's severe bruxers, you open up somebody's mouth and you see that they all have cow teeth, and you need to make sure that you understand how to design this implant that it's not going to receive the brunt of that bruxism. Okay, and that's all about the prosthetically designing of the case. Again, I mentioned this earlier. Well, before I get that one, lack of operator experience, and I say that one that's very important, and that's really the clinician. Inappropriate drill speeds, poor tool choice, the wrong tool choice. Forget to use your cold sterile saline. Just simple mistakes that can be made. That's if that's a problem, because if it's not patient selection, it's got to be, and it's not manufacturer, it's got to be something to do with the procedure and your technique. And I want you to, and that's not a personal attack. That's just an honest look at yourself as a clinician. Do I feel qualified to do this? And most of you know how to get there. It's just a matter of as you do all your procedures, as you learn all your procedures, make sure that you're being honest with yourself and don't get in over your head. Inability for a patient to manage their own oral hygiene is a big concern, because this implant's going to have to be maintained after the fact. Okay, if you don't, it's going to be a failure. And the fact that there might be allergies or things like that, or hypersensitivity to specific components of the implant, low on the chart of contraindications, but it can happen. Okay.
A lot of great information shared today. please, if you have any questions, please reach out to me, reach out to Jessica, reach out to Jean. We are here to help you at any time. I do thank you again for taking your time. Please reach out. Look forward to hearing from you all soon.